Hello friends, this is Dr. Rakesh Mittal, Senior Surgical Faculty. So I have come again with the second video in our series DUM Lagaa ke Hayishaa for the preparation of upcoming NEET PG exam. So अब 3 ही महीने बचे हैं NEET PG में, तो it's a real time to push for it and दम लगाइए and you will get through. Second video is about the varicose veins, right? So I'll be highlighting the important points and will be marking the questions simultaneously which are very frequently asked. So first, starting with the nomenclature of various types of varicose veins. So first is the proper varicose veins, which are subcutaneously dilated veins more than 3 millimeter in diameter, right? Then we have reticular veins. They are smaller in size, 1 to 3 millimeters in diameter. Small dilated bluish subdermal veins. I'll show you the pictures. Then third, we have telangiectasia, also known as thready veins, dermal flare or spider veins or hyphen webs. They are tiny intradermal venules around 1 millimeter or less than 1 millimeter. So less than 1 millimeter are the spider or thread veins or telangiectasia. 1 to 3 is reticular veins, and more than 3 are the proper varicose veins. These are the pictures. So you can see these are spider veins, telangiectasia, less than 1 millimeter. Then slightly thicker, 1 to 3 are the reticular veins, and more than 3 properly thick varicose veins, right? Then we have saphenous varix. Saphenous varix is a term used for a localized bulge or swelling, right? It's usually in the groin that appears on standing, right? Then you have a malleolar flare or corona phlebitica. It's a fan-shaped pattern of telangiectasia, right? So typical pattern gets a name corona phlebitica. Then edema, eczema are the other features of varicose veins, right? So this one you can see. So a localized swelling that shows cough impulse that appears on standing, that is called saphenous varix. And this is the fan-shaped pattern I was talking about, the malleolar flare. Okay, then other manifestations of venous hypertension. All of you know varicose veins is high pressure in the superficial venous system, right? What are the various manifestations? All these are very commonly asked. So a very potential question here. First is pigmentation, also known as hemosiderosis, because the pigment deposited is hemosiderin. It's a brownish blackish discoloration, usually permanent around the ankle, just above the medial malleolus. So the most common site, right? So question 1, what type of pigmentation? Hemosiderin. Then second, the site, the most common site. Then other manifestation, lipodermatosclerosis. Lipodermato, break the term, lipo fat, dermato sclerosis. Sclerosis means fibrosis, fat deposition, fibrosis of the skin or subcutaneous tissue. This is the advanced change of long-standing and the chronic venous insufficiency. So chronic inflammation and fibrosis of skin and the subcutaneous tissue. Skin becomes shiny, loss of fat, tight contracted woody leg. So another question here, woody leg is the term used for lipodermatosclerosis. Achilles tendon is short and contracted. This again has been asked previously, right? And it's a sign of severe chronic venous disease. This is the picture, right? So let's see, as you can see, it's contracted. The Achilles tendon is short, right? And there is fibrosis and it's hard like wood. So this is typical picture of lipodermatosclerosis. Then this is the pigmentation, as you can see here, the most common site just above the medial malleolus or above the ankle, right? And then this is the last stage, the most advanced sign of venous insufficiency, the ulcer formation. Okay, then atrophy blanche. Atrophy blanche is atrophic white skin surrounded by telangiectasia, again a sign of severe chronic venous disease. And as I've already shown you, the last is venous ulcer. This is a whitish appearance around the ankle. This is atrophy blanche, right? Now we come to varicose veins proper. As I have told you, by definition, they are dilated, tortuous, elongated veins more than or equal to 3 millimeter. The most common cause is venous incompetency or venous failure. It may be primary or secondary. We'll just discuss that. So valvular incompetency can be junctional or perforator. Just remember the anatomy, right? So junctions, you have two major superficial veins in the lower limb, great saphenous vein and short saphenous vein. Great saphenous vein, you know, it travels from the foot to the femoral vein in the thigh and drains into that, right? Second is short saphenous vein, that again starts in the foot from dorsal venous arch, the lateral side, and goes behind the knee, and that drains into popliteal vein, right? So these are two major superficial veins. So they're terminal junctions, right? The saphenofemoral junction and saphenopopliteal junction. So whenever we talk about junctional incompetency, we are talking about the failure of the junction, that is saphenofemoral and saphenopopliteal junctions. Along the course in the leg, these veins have multiple perforators, and these perforators connect superficial vein at multiple sites to the deep veins. So when we talk about the perforator incompetency, means numerous perforators, right? So these valves fail and it causes localized dilatations of the superficial veins. And when the valve fails, there is reverse flow from deep vein to the superficial vein. So pressure in the superficial vein increases, that becomes venous hypertension and all those manifestations as we have just discussed, and the vein becomes dilated, tortuous and elongated, right? So this is the basic etiology, and this is how you see the varicose veins. This is how the normal vein looks like, and when there is a reversal of flow, pressure increases, they become tortuous and dilated. Now the causes of valvular failure: congenital, primary, which is idiopathic; secondary is deep venous obstruction, most important cause, and the most common cause overall, again very important question, deep vein thrombosis, right? Secondary varicose veins. Then pregnancy, pelvic tumors can cause compression of iliac veins in the pelvis and can cause secondary varicose veins. Now other risk factors, increased body mass index or tall people, more height, slightly higher risk. Smoking has a doubtful role. Prolonged standing, certain occupations, it is said that like the security guards in a position, they are standing for 7 hours, 8 hours. So that may be one of the risk factors. There is a slight tendency for familial predisposition, right? Now the pathophysiology, this is very important. Okay, the sequence of events, everything to remember about varicose veins, this slide. Okay, increased pressure, first step. In the superficial vein, vein becomes dilated, tortuous, elongated, initially smaller veins, then bigger veins, right? Increased capillary, the pressure is transmitted to the capillaries, increased pressure. So RBCs come out, exudation of RBCs, and they release hemoglobin. Hemoglobin gets converted into hemosiderin. So which pigment is deposited? Hemosiderin. What type of color? Brownish, blackish discoloration. Site I have already told you. The most common site is above the ankle, just above the medial malleolus, also called gaiter area. Then the filtration of proteins and lots of fluid leads to swelling, edema, lipids come out, that causes fibrosis and thickening of the skin, already discussed, leads to lipoderm. This is sequence of changes, right? Lipodermatosclerosis. Then in the end, there is clogging of capillaries, capillaries get blocked, so skin becomes ischemic, and then it starts breaking up, leading to formation of ulcers, right? So this is the sequence of events. Okay, then further on, in chronic long-standing cases, because of dermatosclerosis, ankle keeps on contracting, and simultaneously, because there is higher pressure in the venous system, superficial venous system, deep veins have to exert more pressure, calf muscle has to push blood towards the heart bit more, so it gets hypertrophied, and this typical appearance of the leg is known as inverted champagne bottle appearance, right? This is how the limbs become. Okay, so inverted champagne bottle appearance, very important. Okay, now the clinical presentation, you already know the visible veins. Great saphenous vein amongst all superficial veins is the most common. Pain, typical, again a potential question. You will differentiate pain of arterial pathology with the venous pathology. Okay, the venous pain will be aggravated by hanging the limb down. That will further increase the pressure in the venous system, whereas it will be relieved by elevating the limb. Arterial pain will be exactly opposite. Arterial pain gets relieved by hanging the limb down because gravity helps there, and it is aggravated by elevating the limb. So opposite. Okay, swelling, you know, because of edema. Then skin changes. In this sequence, typical, we just saw it in pathophysiology, pigmentation, eczema, then the lipodermatosclerosis and ulcerations. I made a mnemonic for this, PELU, PELU. So these are three different pictures of varicose veins, how they look like. Now CAP classification, the most important. In last 4 years, twice it has been asked, some question has been asked based on CAP classification, mostly the clinical, right? So this is the full form of CAP, clinical classification, etiological classification, anatomical and pathological. Everything is based on what we have just discussed, right? Clinical, this is the most important part, right? And this is very easy to remember. Go back to that slide again, pathophysiology, right? So what is the first change? C0 is nothing, normal limb, no obvious varicose veins. C1 is the smallest varicosities. Which one we discussed? Reticular veins. Reticular veins, the small, less than 3 millimeter, Dummel flares or telangiectasia, all these smaller veins, they come under C1, right? So C1, smaller vein. Then C2 is properly, next step is bigger veins, properly formed veins. So very easy to remember if you remember this way. And then C3 is edema, fluid comes out, C3. Okay, so smaller veins, bigger veins, then the fluid comes out, so edema sets in, C3. Then C4 onwards, the skin changes. So first is pigmentation, C4A. Then lipodermatosclerosis, C4B. And then the ulcers, C5 and C6, right? So it's easy to remember. Okay, so C0, no venous disease. C1, telangiectasia or reticular veins. C2 is properly formed varicose veins. C3 is the fluid comes out, edema, then the skin changes. C4A is pigmentation, eczema or malleolar flare. C4B is lipodermatosclerosis or atrophy blanche. C5 and C6 are ulcers. C5 is healed venous ulcer and C6 is active venous ulcer. So this is clinical classification. A suffix S or A is added if the patient is symptomatic or asymptomatic. Then etiological, what we have already discussed, three causes. EC is congenital, EP is for primary varicose veins, ES is for secondary, yani ki post deep vein obstruction, and EN is no venous cause identified. Then anatomical, which system is involved, superficial, deep, perforator or both. So AS for superficial veins, AP for perforator veins, AD for deep veins, AN no identifiable venous location. Then pathophysiological, we have seen either it's pure reflux or secondary to obstruction or mix of both, right? So PR is pure reflux, PO is secondary to obstruction, both reflux and obstruction, and no identifiable pathophysiology. So this is CEAP classification. This is again very, very important. Different name tests, clinical tests for varicose veins. Most important, which has been asked maximum number of times, is Perthes test, right? Brody-Trendelenburg test, you should know. Even this has been asked. What exactly is the purpose of Brody-Trendelenburg test? Junctional versus perforator incompetency. This clinically differentiates whether the patient is having junctional incompetence or perforator incompetence or both, right? Morris's cuff impulse test, Schwartz test, they are to confirm the varicose veins, just the venous incompetence, right? It has got nothing to do with the anatomy, right? So anatomy differentiation is only Brody-Trendelenburg test, that whether junctions are involved or perforators are involved. Then Figans is to identify incompetent. This is palpation along the vein, and where there is a dip pit in the fascia, that will be the site of incompetent perforator. So this again has been asked. Okay. Then as I told you, Perthes and modified Perthes to check the deep vein patency, deep vein thrombosis, whether the deep veins are blocked or not. So that's a clinical test. So very, very important. Now investigation of choice, Doppler ultrasound. Again this has been asked. Doppler ultrasound or duplex scan is the best, non-invasive, and overall the investigation of choice. It confirms the varicose veins, differentiates between junctional and perforator, tells you which all perforators are incompetent. Is there thrombus in superficial vein, whether the deep veins are patent or not. It helps in marking of the junctions and accurate marking of the perforator. So everything we need to know about the diagnosis and the treatment, we get it on the duplex scan. Now two very important signs, again they have been asked, Mickey Mouse sign and saphenous or Egyptian eye sign. So this is the typical Mickey Mouse sign. Orientation of the three vascular structures in the thigh. You know, laterally it's common femoral artery, then medial to it is common femoral vein, and that's the saphenous, means great saphenous vein draining into the common femoral vein. So this is Mickey Mouse sign, and this is Egyptian eye sign. This is basically again there are various facial layers in the thigh, and between these facial layers the appearance of great saphenous vein, that's a great saphenous vein. Okay, so and these are the facial layers. So this is typical Egyptian eye sign. Now the treatment, first is elastic compression, stockings or bandage. Remember, they are not curative, they are only for relief of the pain, only for symptomatic relief. Okay, so that's one. Then second is injection sclerotherapy. So this is not curative, only for symptomatic relief. Sclerotherapy, again it's not helpful for properly formed varicose veins, bigger varicose veins. It is indicated only in smaller veins, reticular veins or dermal flares. C1, that is to CEAP classification, smaller than 3 millimeter. Okay, not useful for bigger veins more than 3 millimeter. It can be given directly or via a catheter in the form of sclerotherapy. We'll discuss in details later. So again a potential question here, what are the indications for sclerotherapy, what are the types of sclerosants used, and what is the technique used. Technique I'll discuss it in the end. The sclerosants most commonly is sodium tetradecyl sulfate. Alternatives are ethanolamine oleate, polidocanol or phenol in oil. Polidocanol and phenol in oil, you know, that also used as sclerosants commonly for the hemorrhoids. Okay, this is directly injecting sclerosant in a reticular vein. Now the back to compression stockings, again a potential question here. What is the role of the compression bandage? As I told you, it's only for symptomatic relief. It compresses the veins, reduces the venous pressure, improves the venous return, so pain goes down. British classification, how much pressure? It's a graduated pressure depending on how much is the requirement of the patient. Class 1, class 2, class 3, class 4 stockings based on the pressure, 14 to 17, 18 to 24, 25 to 35, and more than 35 millimeters of mercury. Now third segment is surgery. So first is stockings, second is sclerotherapy, third is various types of surgeries, and last will be the non-surgical techniques or minimal invasive techniques, the newer techniques which are called endothermal procedures. So first, Trendelenburg operation, very, very important, has been asked n number of times. Remember, this is useful for junctional incompetence, junctional, saphenofemoral junction, saphenopopliteal junction, right? And what is the procedure? Flush ligation of great saphenous vein or short saphenous vein, depending on which junction you are doing, right? Flush ligation. Flush ligation means as close as possible. Okay, suppose this is the femoral vein and this is the great saphenous vein draining into it. So tie the great saphenous vein as close to the femoral vein as possible. and then divide it. So just ligating and dividing it at the junction is called Trendelenburg operation. But just the ligation alone is not sufficient. There will be a very high rate of recurrence. So this operation is not useful in today's scenario. Then to reduce the recurrence, in addition to ligation, we do stripping of the superficial vein. Stripping can be done, but now newer techniques, lesser invasive techniques have come up. So now even stripping is rarely done, only at smaller places where the advanced technologies are not available. Right now, two important things, the very important about stripping. First, stripping has to be done above the mid calf level. It should be done above the mid calf level. What is the reason for that? In the lower part of leg, great saphenous vein is closely accompanied by saphenous nerve, and short saphenous vein is closely accompanied by sural nerve. Remember this, the most potential question from this entire video. Okay, great saphenous vein is accompanied by saphenous nerve, short saphenous with sural nerve. So if we do stripping in the lower leg, it can cause injury to these nerves, and patient can long-standing neuralgia, post-operative severe pain. These are cutaneous nerves. Okay, so stripping is done only till mid-calf level. And second, stripping is contraindicated if deep veins are blocked. That is why I emphasized on the point that before proceeding for the treatment, you must know the status of deep veins. Why it is contraindicated? Because if deep veins are blocked or thrombosed, then the superficial veins are the only veins that are helping in returning blood from the leg or lower limb. So if you remove the superficial veins and deep veins are already blocked, there will be no venous return from the limb, right? So there will be huge venous blood blocked in the lower limb, right? So that we don't want. Patient can go into venous gangrene. So that's why stripping is contraindicated in DVT. Okay, so now this is about the stripping, how the stripping is done, right? So that's a saphenofemoral junction. So you tie the great saphenous vein and divide it. From this end, we insert the stripper instrument along the vein. Then suppose this is the level to which we want to remove it, above the mid calf. So then take out the stripper from here. Then once you have inserted the stripper into the entire vein, and then pull it off from the above, and as you can see the real picture, the entire vein comes out along with the stripper. And this is the picture of, so another potential image based question. This is a vein stripper. Okay, this is how different pictures showing you how it looks like. So this is about the ligation and stripping. So ligation alone of junction is Trendelenburg. Ligation plus stripping is another procedure to reduce the recurrence rate. Now ligation, again there is another important point. Not just the superficial vein or great saphenous vein, all the nearby tributaries of great saphenous vein also have to be ligated to reduce the recurrence rate. So there are 6 great saphenous vein tributaries close to saphenofemoral junction. So this is the great saphenous vein. So don't just tie the great saphenous vein. The tributaries of great saphenous vein also have to be ligated to reduce the recurrence rate, and these are the 6 tributaries. Okay, now the perforators. Trendelenburg, ligation and stripping are for junctional incompetence. Now what we do for perforators incompetence? So perforator incompetence, again very important, Cocket and Dodd operation. This is similar to Trendelenburg. There also we do flush ligation of the great saphenous vein or short saphenous vein. Cocket and Dodd operation is again the ligation of perforators. Subfacial. Subfacial means under the deep fascia, right? This is deep fascia, this is perforator, this is superficial vein, this is deep vein. As I told you in Trendelenburg also, as close to deep vein as possible. So when we ligate the perforator, again the same principle. Close a ligate here, not here. This is the correct site for ligating. Closer to the deep vein, flush ligation. So it's under the fascia. So that's why we call it subfacial ligation of perforators. Now same procedure, this is open technique, multiple stab incisions. Wherever you first mark the perforators, give a small stab incision, identify the perforator, go under the fascia, divide it, ligate it and divide it. So this is open. Same procedure can be done endoscopically also, called SEPS, another very important question. Subfacial endoscopic perforator surgery, full form of SEPS. So that's SEPS. As you can see, a small stab incision, the telescope goes inside, go under the deep fascia, and that's operating instrument, and you divide, ligate and divide all the perforators under the deep fascia. That's SEPS technique. Then another excision technique of multiple perforators is TRIVEX. This is called, not very popular question, not very frequently asked, trans-illuminated vein excision, also known as TIP, trans-illuminated powered phlebectomy. Phlebectomy, excision of cluster of veins. Trans-illuminated means you do it under vision. That's a procedure. So one side, small stab incision here, you insert a light source that can show you, highlight all the veins, the cluster of veins, and opposite end another stab, insert a resectoscope instrument that takes out the cluster of veins. Another picture showing you the same. Illumination device from one side and then resection device from the other side, and you remove this cluster of veins. That's TRIVEX procedure, not very popular, not done routinely. Now this is the most important, right? Endothermal, the latest techniques, right? No surgery, no major surgery, no stripping is required, right? Radio frequency and laser, these are the two techniques. Laser is the latest and it is the treatment of choice. Another important question, right? So radio frequency ablation, also called venous closure or venous procedure. Again, you do a small puncture, insert a catheter through which you give the radio frequency energy to it, and it's a heat procedure. It produces heat. That's why we call them endothermal procedures, right? With this heat, the vein from inside collapses and closes. So that's radio frequency. EVLT is endovenous laser therapy or endovenous laser ablation, and this is the most latest and treatment of choice. This is radio frequency ablation. As you can see, that's a dilated vein. Make a small stab, insert a catheter, start coming out by applying heat radial manner, and as you withdraw it, so you can see the vein is collapsing, the catheter is going down, and this segment has already collapsed with the heat energy. This is laser, similar, same procedure, right? So that's a great saphenous vein. You make a small puncture. These are ultrasound guided, under Doppler ultrasound guidance. You are doing these procedures. Insert a laser fiber, and then laser energy is applied, and you keep withdrawing it, and whatever laser you have already applied, that segment of vein will keep on collapsing and closing. This is the real picture. You can see before laser treatment and the result after laser treatment. It's almost 100% improvement. Now just 2-3 things about laser energy. The wavelength used is 1470 nanometer, and it delivers energy at the rate of 60 joules per centimeter. Radio frequency ablation uses electromagnetic current to generate thermal energy, 20-second cycles, 120-degree temperature. Okay, now the form sclerotherapy, I skipped it in the beginning. One of the techniques of giving sclerotherapy, as I told you before also, sclerotherapy is not curative for bigger veins, it's only for smaller veins, reticular veins less than 3 millimeter. The benefit of this is it can be used as an OPD procedure under local anesthesia, don't require admission, don't need any anesthesia. So general anesthesia. And the technique used is called Tesserae method. Again, very important question. How we prepare, Tesserae is basically preparation of the form, right? So in this what we do is, as you can see the technique, so this can come as an image based question, right? So 2 syringes connected by a 3-way tap. So you take 1 ml of sclerosant and 3 ml of air. So it becomes 1:3. 3 or 1:4 also you can take, mixture of sclerosant and air, and then you oscillate this mixture between these two syringes for around 10 to 20 times, and when you do that, a foam, white colored foam will be prepared, and that foam is used to inject inside the reticular veins, and it's a kind of chemical sclerotherapy that causes aseptic sclerosis inside the vein, similar way like use laser and radio frequency. Okay, so two syringes connected by a three-way tap, 1:3 or 1:4 ratio mixture of sclerosant and air, oscillated between vigorously between these two syringes 10 to 20 times. At one time we inject 1 to 2 ml of foam, and maximum volume of foam per session should not exceed 10 to 12 ml, because there can be some leakages outside the veins also under the skin that can cause damage to the skin and subcutaneous tissue. So we have to be careful in that aspect to prevent complications. So this is the final injection, as you can see, right? So that's a scalp vein inserted into the reticular vein, and you are injecting the prepared foam by tertiary technique into it. Then endovenous glue procedure not used, just remember the name, cyanoacrylate. This has been tried to close, injected into the veins, but still the overall the best treatment is laser ablation. Now last, the complications of surgeries of varicose veins. Quick word: wound infection is the most common complication overall. Bruising and ecchymosis, particularly most common after stripping procedure. Nerve injury, this has been asked many a times. I have told you before also which nerve injury. Mostly they give you a clinical question that a patient undergoes ligation and stripping procedure, and now they will give you area of pain, right? So from that you have to identify which nerve. So great saphenous vein is accompanied by saphenous nerve, short saphenous vein is accompanied by sural nerve. So that's the most common serious complication, the nerve injury causing pain. Then venous thromboembolic complications can happen, or recurrence. Recurrence is more common with short saphenous vein compared to great saphenous vein. So this is all about varicose veins. Thank you.